Good evening, everyone. Good evening, good evening. It's nice to have such a huge crowd here tonight. Thank you all for being here. My name is Bill Mejia. I am the Director of Cancer Support Services. I'm the Director of Cancer Support Services at Lucy Kirchie Cancer Center. My name is Bill. I want to welcome everyone tonight. We're very excited to have such a big crowd and such a great crew of presenters, professionals and physicians. So I wanted to just say a few things before we get started. At the end of the evening, you'll get a packet when you leave. And inside that is a lot of information about a lot of the programs and services that we have here at Lucy Kirchie. A lot of them are our support programs, our exercise programs. We have Tai Chi, yoga, an exercise class. We have meditation. And we also have a number of support groups. And one of them is the prostate support group. So we're very happy to have that. It's a great group of men getting together, and a lot of times their wives or their partners to come and share information, share experiences. I wanted to call out one member, Bill Stark. Where are you? Oh, you're right there. Oh, that was easy. So Bill Stark has been a constant member for our group for a very long time. He also attends some other groups in the Valley. And I just wanted to point him out as just a great resource. If you have any questions about a personal experience or any more information that you want, Bill is here. I told him I would call him out, so thank you, Bill. So please look at the calendar of events, if not for you, for anybody who you know who may be living with cancer, who may benefit from our support programs. A lot of you have taken your food or partook in our wonderful dinner. It's going to be up all evening. So I was trying to mention that to some of you, like, if at any time you want to go out and have some of this wonderful food, please do. It's going to be open all evening. The only thing we ask is that we're just going to keep going with the presentation, so we're not going to take a dinner break and interrupt. So the only thing we ask is that when you go outside to get your food, just be a little quiet so that you're not interrupting the presenters. But please, there's plenty of food out there. At the end of this, we're going to have a drawing. You got a ticket, and it's for dinner for two, or if it's just a big gift certificate for Wally's here in Rancho Mirage. So you're going to want to stay for that. That's going to be a nice one. Wally's is great, and we're very, very happy to have that gift from them. So I just want to thank a few people for tonight. First of all, Christiane Tyler. I think she's out there. She's probably putting more food out there. I hope you're all impressed by the wonderful spread that we have outside. Isn't it great? Oh my God. And we're very proud because that's our own catering company. So Christiane Tyler is ahead of it all, and she's just been wonderful in putting this all together, in making sure that we have healthy snacks and healthy meals for you. So about almost 2 years ago, I started working here, and I took over for Allison Sachs, who is over here. Hi, Allison. So many of you recognize her or maybe know of her, but she was in the position before me. And when I came on board, and she's working for us now as a contract employee doing lectures and doing special events. So it was wonderful for me because we got to keep her, and I got to work with her. One of the first things she said to me when she first started was, I want to do a prostate symposium. We need to do this. And it was just a vision that she had 2 years ago, and it is here now. So we're very happy. This is our first symposium. So just for prostate cancer, we put a lot of time into it. I'm sorry, I should say. Allison put a lot of time into this. I just get to stand up here and pretend like I did it all. But it was a lot of work for her, gathering all the physicians, getting the topics. And so this is exciting for us, and we hope to have it every year. Is there an evaluation form in the packet? So in the packet that you there isn't. So anyway, with the results of what happens tonight, we're excited to have it next year, and we'll see how it goes. But we're very excited about this. So, Allison, thank you for all your work that you've done for tonight and putting this all together. And the other person behind the scenes always is Cheryl Sessi, our program coordinator. She's back there taking pictures. So both she and Allison work very hard together to put this all together, along with Christiane, Tyler, and also Aaron Green over there doing the AV for us. So with that, I'd also like to introduce John Stoneman. Put you on the spot, John. John is part of our research program, and he'll have a table outside providing information about all the research studies that we have going on. And it's important to know that all the medications, all the treatments that are going on now are a direct result of what happens during research. So please see, there's a number of activity, a number of research projects going on. So John is the person to see when we're done. So with that, I'm going to hand it over to Allison. Oh, and one more thing. In this past year, some of the physicians worked on this great brochure that we have made, Expert Care and Compassionate Support at Every Step. And it's just for Eisenhower Health, for our prostate patients. And so we have this also available when you leave, and it is for those who have, it's mostly for a new diagnosis. When you get that diagnosis and you're wondering what's going on, what are my options, what do I do now? This is the booklet to look at. So we have that outside for those of you who would like that. So with that, Allison, take it over.
Good evening, everyone. It really has been a lot of years and a lot of work, and I really am delighted. And sitting in front of us are 4 physicians and a DPT, that's someone who has their doctorate in physical therapy, who I think between the 4 of them haven't been here. They've been here over the last 5, 6, 7 years they've joined us. And it's really a testament to watching Eisenhower grow through this valley and bringing the best healthcare possible. Bill was kind, and aren't I lucky to have such a nice boss? I never thought at my age I'd have a new boss that's lovely and so helpful and supportive. I've been wanting to do this symposium for probably 10 years. And I don't say this cutely, but I mean it. I am the prostate queen, for those of you who don't know that. This is an area I have worked in for over 20 years. I sit on the scientific advisory board of Zero Prostate Cancer, which is the world's largest nonprofit dedicated solely to the education and support of prostate cancer patients. So I was not able to get this off the ground until these physicians joined us, and they took the lead. And as we all know, when the doctor says they want something, especially at Eisenhower, the doctor needs, and they get it. So I want to thank them publicly, and I'll introduce them all later. But I really am excited to stand up here and see all of you out there. So with that, let me do some introductions and move us forward. It is an honor for Bill and I to have you join us for this first of what we know will be an annual prostate cancer symposium. But I want to say something about that. Your presence speaks volumes, because it reflects all the commitment, not only to your own health, but to the well-being of your loved ones and our entire community. You know, choosing to spend your time learning, asking questions, engaging in conversation is one of the most powerful steps anyone can take in their journey through prostate cancer, and truthfully through any cancer. This is a field I have worked in for 40 years. We're living in a time of remarkable progress. Advances in detection, treatment, survivorship are offering more hope than ever before. But with progress, as we all know, comes complexity. And that makes being an informed and educated consumer, especially about prostate care, absolutely essential. Understanding your options, asking the right questions, and partnering with your healthcare team will, I know for a fact, make a meaningful difference in outcomes and quality of life. So congratulations, give you all your own round of applause for being here. And just some housekeeping and one more introduction. We will have educational information bags from a company called Bagot. They are a nonprofit and they exist solely to provide patient education and information. We never expected this turnout. So there are over 100 of you and there are 75 bags. So we worried, we fretted over this, believe me. However, they are specifically for those diagnosed with prostate cancer. There is a bag with information for newly diagnosed, and there is a bag for information for those with a more advanced stage of disease. So we only ask that you don't take or accept a bag unless you're in treatment. Let's see if we can get those into those other folks' hands, if that's okay with you. The other thing I'd like to do is interview someone in what is a relatively new position at Eisenhower. Abby, are you in the room? I should put my glasses down so I can look. There you are. Abby's over there waving at us. Abby Mata Lopez is our fairly new prostate nurse navigator. Abby is an oncology certified nurse and as a prostate cancer patient advocate, because that's what a navigator is, along with their oncology social work colleagues, they're advocates. As a prostate cancer patient advocate, she will be providing a constant point of contact for those diagnosed with prostate cancer at Eisenhower. Abby will help with questions regarding care coordination, connection to supportive care services such as nutrition, pelvic health, emotional support, and hopefully, having worked with Abby for 20 years, 15 years, long time, I know, be the person really to help with any confusion and help ease the stress, which we all, myself included, know what it feels like when we hear the words, you have cancer. So with that, let me introduce our docs and we will get going, okay? We're gonna start off with Dr. James Hendricks. He's a board certified urologist and he sees patients in Rancho Mirage at the Eisenhower Urologic Specialty Clinic. He attended medical school at the prestigious Columbia University College of Physicians and Surgeons, and then completed 2 years of general surgery residency, 4 years of urologic residency at Columbia Presbyterian Medical Center in New York City. After completing his training, Dr. Hendricks spent 4 years as a urologist for the US Navy. Thank you for your service, doctor. Spending 2 years in Yokosuka, Japan, and 2 years at Naval Academy in San Diego. After being honorably discharged from the Navy, he began private practice initially in the Bay Area, was in Napa Valley, and was in Hemet. He joined us in Eisenhower Health. How long ago, Dr. Hendricks now? 3 years, thank you. He practices all facets of urology, doing laparoscopic urology since 2007 and robotic urology to 2002, robotic prostatectomy, excuse me. Dr. Hendricks went into medicine because he loves people and the science of medicine, and urology is the perfect mix of both. As he says, and I quote him, "It is taking care of all of the different types of people we see in medicine that brings the most joy. Being able to offer them therapies to improve their health and quality of life is extremely rewarding." Next, I'd like to introduce Dr. Delshad Ahmad. Dr. Ahmad is a board-certified medical oncologist and hematologist dedicated to providing personalized cancer care. He received his medical degree from Damascus University in Syria, where he did a residency program in internal medicine as well. Once in the United States, he completed a residency in internal medicine at the Hurley Medical Center in Flint, and he finished a fellowship in hematology oncology at Michigan State University. Go Spartans, I bleed green and white. Dr. Ahmad is director of thoracic oncology at Eisenhower Lucy Kirchie Cancer Center. With regard to approach for patient care, he strives to provide patients with all options, possibilities, and treatments with regard to treating their disease. Every patient is unique and every treatment is unique, states Dr. Ahmad. I want to understand my patients' goals, provide them with the information they need to accomplish those, and partner with them in their treatment plan. I am with them all along with their journey toward health. Oh, there we go. Dr. Nasseri, hi, I'm so glad you made it. I was getting so nervous, Doc. Welcome. Dr. Ryan Nasseri is our colleague from UCSD Health, which is Eisenhower's affiliate healthcare partnership. He is fellowship-trained urologist with a focus in men's urologic health, including male fertility, low testosterone, erectile dysfunction, Peyronie's disease, and prostatic urology. He is an expert in microsurgical vasectomy reversal, varicocele, how do you say that? Thank you, varicocele. Thank you, I've never seen that before. Varicocele repair, testicular sperm extraction, surgical management of Peyronie's disease, and erectile dysfunction. He obtained his medical degree from the Sackler School of Medicine in Tel Aviv, did his fellowship in andrology, male fertility, and sexual medicine at University of Washington School of Medicine in Seattle, and his residency at UC San Diego. He finds it rewarding to be able to connect with patients about sensitive issues and strives to offer all his patients personalized, evidence-based treatment plan and guide them on a path to better health and wellness. Last but not least, for the physician intros, Dr. J. Bishoff. Bishoff is board-certified urologist with an emphasis in endourology, robotic, and reconstructive surgery. He sees patients at Eisenhower's Urologic Clinic in Rancho Mirage. While in the United States Air Force, again, thank you for your service, Dr. Bishoff. Dr. Bishoff earned his medical degree at the Uniformed Services University School of Medicine in Bethesda, Maryland. Completed his residency at Joint Military Medical Command in Lakeland, Texas, and earned a fellowship in endourology at the Johns Hopkins Medical Center, very prestigious in Baltimore. After his medical education, Dr. Bishoff was deployed to Iraq during Operation Iraq Freedom. Specializing in robotic minimally invasive surgery, Dr. Bishoff is trained on the newest generation of surgical robotics, which is a single port robotic surgery. Instead of multiple surgical incisions, single port is only one incision, which affords for less potential for infection and shorter hospital stays. Dr. Bishoff partners with his patients, offering recommendations for treatment that afford the best path to lead the best possible life. Dr. Patel, I almost forgot about you. My apologies. My colleague and friend. Dr. Kamal Patel is board certified in radiation oncology and the medical director of the Eisenhower Lucy Curci Cancer Center Bighorn Radiation Oncology Center. He earned his medical degree from the Chicago Medical School and completed his training at Oregon Health and Sciences University, Portland, Oregon. He came to Eisenhower from the Cancer Treatment Centers of America near Chicago. Late in medical school, Dr. Patel did a rotation in radiation oncology and quote, "I never looked back. My field allows me to collaborate with the healthcare experts from all fields and use technology to give every patient the best possible care. I am very blessed to be a provider of healthcare," states Dr. Patel. "It is so gratifying to be able to make a difference in my patients' lives. I love being an oncologist and being able to support and guide patients and their caregivers during such a difficult time." What a lovely quote. Thank you, doctor. And last but not least, Willie Quach, doctorate in physical therapy. He earned his doctorate from California State University, Northridge, and completed his specialized training through the Herman and Wallace Pelvic Rehabilitation Institute. He's been a practicing physical therapist since 2018 and joined Eisenhower 2 years ago, where he serves at the Dolores Hope Pelvic Health Clinic. Willie is passionate about creating a safe, private space for patients to openly discuss intimate pelvic health concerns, and they often feel they can't share those concerns elsewhere. He loves guiding them through their recovery, working closely with the providers here so they can confidently return to an active, fulfilling life to enjoy. And with all of that, I welcome you, I thank you, and I believe, Dr. Hendricks, you are kicking us off. Thank you.
Is this working? Yeah. Happy, is this winter or summer? Do you guys know? I can't tell. So according to the schedule, my talk is over right now, right? Anyway, we have a lot of speakers tonight. I'll start. The order's a little different, but I'm the first speaker because I'm the worst speaker probably. So we'll get that out of the way, then you guys can listen to everybody else, okay? So the first, we're gonna talk about early stage treatment for prostate cancer with curative intent. I'm talking about surgical procedures. I'm not talking about radiation. That's what Dr. Patel is here for. He's a radiation expert. I know a little about radiation, but I'll go through this pretty quickly. So prostate cancer is the most common cancer in American men. It's the second leading cause of cancer death in the United States, second to lung cancer. But the interesting thing is most men with prostate cancer do not die of prostate cancer. They die of something else. That's an important thing to realize. And so prostate cancers, there's low-risk prostate cancer, then there's high-risk prostate cancer. Low-risk prostate cancer, there's in our booklet that shows you there's different grades of prostate cancer when we do biopsies. There's low grade, which is Gleason's 3 + 3 = 6, which is also called grade 1. And then there's higher grade up to Gleason's 10, which is Gleason's grade 5. Anyway, we stratify prostate cancer patients by the risk categories. Low-risk prostate cancer patients usually are not going to die of prostate cancer, so oftentimes we don't recommend doing any sort of active treatment. We would do something called active surveillance, which I won't go into specifically right now. People who are in the more intermediate risk to high risk, who have a higher PSA, a higher Gleason's grade, have a higher risk of recurrence, and don't have any evidence of disease outside the prostate, then these are people that we look towards more doing active therapy, either surgery or radiation. I'm not going to go into a lot of detail about this in the interest of time. This is straight from our prostate cancer book. I stole it. It's from that book that she talked about. This just shows early stage prostate cancer from this is the bladder right here. This is the prostate. Stage 1 is just one side of the prostate. Stage 2 is a larger lesion on one side of the prostate. 2Bs on both sides of the prostate. Stage 3, it can grow into the seminal vesicles here, and stage 4 is if it goes to more structures like the bone. So usually when we're thinking about curative therapy, we're thinking about the stage 1 to stage 3. Again, about 30% of patients that are newly diagnosed with prostate cancer actually do not need to be treated, and they can undergo active surveillance, which does not mean do nothing. Basically, it also depends on the age of the patient and the overall health. If somebody's 85 years old and they have low-risk prostate cancer, a lot of times we don't even do active surveillance. We'll just do what we call watchful waiting, which means more than likely prostate cancer is not going to kill you in the next 15 years, so why would you treat somebody who's not going to live that long? If you have a life expectancy of more than 10 years, then generally we do active surveillance if you're low risk or intermediate risk, favorable we call it. And that involves basically, it doesn't mean doing nothing, but we'll check your PSA every 3 to 6 months. Usually we'll do rebiopsies of your prostate within a year of the first biopsy to make sure it hasn't grown, and then periodically from then out and keep an eye on it. About 30 to 50% of people on active surveillance will actually end up being treated in the future. So some actually do need to be treated, but the benefit to doing this is that there are side effects from doing treatment. Obviously, surgery or radiation has side effects. And if you do end up having treatment, say 3 years from now rather than now, that means you're living 3 years longer without those side effects. So it makes sense to wait. Survival is the same for people who go on active surveillance versus those who are treated if you're the right candidate for that. Have radiation for the entire prostate. So this is when Dr. Bishoff and I were training when we were younger. Everything was done open, and we did this. This is a total exaggeration, but there's a big incision we made from the belly button down to the pubic bone. It's usually probably 2/3 of that. And you do an open operation, and it's really bloody, and it's hard to see, and we're bending over, and it's very uncomfortable. And a third of patients get transfused. They have to have a catheter for 2 weeks. There's pain. They're in the hospital for 3 to 7 days afterwards. This is all done this way until the early 2000s, pretty much. And then when we were in training, laparoscopy was just beginning for doing hernia repairs, or mainly for doing gallbladders first, and then appendectomies. So when we were surgery residents, we were just starting to do laparoscopy. So we were lucky enough to be trained in laparoscopy. I personally took out 180 gallbladders when I was a resident in surgery. By the time we went to do urology, they were doing these open surgeries, and we're all like, why are you guys doing these open? Maybe you could do it laparoscopically. The problem is that the attendees, the surgeons that were teaching us, had no experience doing laparoscopy, so they couldn't do it, and they didn't dare try. And the ones that did try had a really hard time. So, but then in the early 2000s, the late 90s, people started doing laparoscopically. Then year 2000, the robot came out, the Da Vinci, the first generation robot came out, and it started being done robotically. And now, either laparoscopically or robotically, generally there's five incisions. There are various different places, usually like this, but there's usually 5 incisions that are small. One's three or four of them are dime size, and the other one's just big enough to pull your prostate out. Either that way, and now there's a new single port robot that Dr. Bishoff uses, which is just one incision, which is instead of having 5 incisions like this, you have one incision, which is bigger, where they put all the, we'll go more into detail about that. So the incisions are usually 5 of these, or one that's about a quarter the size of this one. And obviously the recovery from this, well, I'll go over that a little bit later. Let it go quick. So to talk about surgery, we got to talk about anatomy. It's very, so you have an idea of what we're talking about. So this is the prostate right here. This is the rectum. This is the bladder, and this is the urethra. So when we're doing prostate cancer surgery, the things that we want to avoid, obviously, is the sphincter is right here. This controls your urine. So you want to spare that so that you have continence, you don't have leakage after you urinate. This here is the pelvic plexus, which supplies the nerves to your penis for erections, which obviously important. So when you're doing surgery, we obviously, if we can, and if you don't have high-risk disease, we can surgically spare the nerves, leave these behind. But it depends on, if you have low-risk disease, you can certainly do that. If you have high-risk disease, there's a higher chance that the prostate cancer is growing outside of your prostate. If it grows outside of the prostate, it could be going into the neurovascular bundle. So if you have high-risk disease on one side, generally, you can't really spare the nerves to the penis. You need to take it out in order to try to cure you. We're doing the surgery for curative intent, so there's no point in saving the nerve if you're going to have a positive margin afterwards. If you have a positive margin, you have cancer left behind, so you still need to get further treatment on that. So, so erections can be affected by surgery. We also disconnect this is the bladder, this is urethra. We need to re-sew the bladder to the urethra. So there can be problems with urinary incontinence afterwards. One of the reasons I'm showing you this is when we do open surgery, we're looking down. Some of the surgeons can say they can wear loupes and they can see very well, very magnified. And you can do a good job of sparing this and connecting and do a good job sewing these back together. But when we started doing these robotically, we realized that when we did that, we could kind of see where the urethra was in the bladder. We sewed together, just throw stitches down, 4 or 5 of them, and hoping it would work, and leave a catheter for 2 weeks. But when we do these with a robot, we actually look in with the camera as a 3-dimensional camera. We can bring that camera as close as you want. So you're literally, you can magnify it by 200 times. So we can see the entire thing. So when we sew this back together, we can actually see we do a running stitch, so it's completely watertight. When we irrigate the bladder afterwards, in open surgery, we irrigate the bladder, we're done, and we see fluid coming out everywhere, leaks. So you have to wear a catheter for 2 or 3 weeks for that to seal. With this, we irrigate it, and there's no leakage at all. So the result of that is, with the old surgeries, incontinence, it can be a big issue, but these days, long-term urinary incontinence, meaning wearing a pad after a year, is what just happened? Did I do that? Anyway, the chance of having significant urinary leakage a year after surgery now is very low. And that's, there we go. So I'll just go over these very briefly. This is in the year 2000, the first Da Vinci robot came out. This is the big, huge machine. But the benefit was we sat in this console right here. We looked into this camera. This is a 3-dimensional camera. We had this big thing that was on the bedside that held 3 robot arms that we would function. This is the first generation robot that came in 2000, 2008. The 3rd generation robot came out, which was a little bit finer, but you can see, you guys have probably all seen this before, but the surgeon sits on the console And what we do with our hands and these instruments down here is transferred to the tips of the instruments and the robot, which go through these small incisions. This came out in 2009, and the technology kept getting better. The visualization got better. The instruments we can put the instruments through smaller ports, so they're smaller incisions. And then in 2000, this shows we have our hands in the robot here, and what we do with our hands is transferred directly to these instruments. So the good thing about this compared to laparoscopy is when we do laparoscopy, it's like doing chopstick surgery. We have two instruments and there's no range of motion. You can only, if you want to sew, you're just kind of moving around awkwardly. With this, it's like doing open surgery. When we stitch, you use your wrist and your hands and your fingers. And with this, actually your wrist movements are replicated exactly by the instruments in here. So it's much easier to sew. We can sew much better. That's part of the reasons why the anastomosis is so much better now than when it was open. We can see much better. You can literally see as we tease a nerve off the prostate, you can see really well if it's stuck or not and do a good job of hugging the prostate to spare the nerves. This is the 2014, I think the XI came out, which is just now it's slimmer, arms are smaller, still smaller trocars. In 2000, I think it's 18, Dr. Bishoff, the SP robot came out, the single port that Dr. Bishoff uses, which is nice because it's all the instruments come through a single port here. And so the way they do that is the instruments come through, then they fan out like this. And so you can do it all through one incision. You can pull the prostate out through this incision. So I just came back from the NARIS, which is the North American Robotic Urological Society, I think it's called. Dr. Bishoff and I are both members of, and go ahead. There's a lot of people in the country that are doing single port robots, prostatectomies. But most people are still doing multi-port prostatectomies. Most of the guys who do huge volumes are doing multi-port prostatectomies. The outcomes, both can be done as an outpatient, either go home the same day or the next day. But there are some benefits to doing this. There's less shoulder pain and things like that. There are some studies that show they might need a little bit less pain meds, but most patients go home either way without any oral narcotics. And then last year, the latest multi-port robot came out, the Da Vinci 5, which is just a little more ergonomic and smaller. Basically the same thing, but the technology is better. It gives you some haptic feedback so you can feel the tissue you normally can't feel with the regular Da Vinci robot. But this just shows, again, this is the new version, which for us is nice because the old version we had to stick our head and look down like this. And with the SP robot, you do too. You look down, and by the time the case is over, your neck is killing you. With this thing, you can move the screen right up to your head and just lean right into it. And the camera, the optics and everything has gotten better. And this is sort of what we're looking at. Oh, so. And just in December of last year, actually just 3 months ago, there's a new, Da Vinci's had a monopoly on the whole market. And so all the robotic prostatectomies are done by them, but FDA just cleared the new Medtronic robot, which is called the Hugo. I don't know how they came up with that name, but it's a little different in that instead of having one big console that has 4 arms, they have 3 or 4 different consoles that you bring in each one and there's a separate arm. And this, instead of looking into a 3-dimensional camera, you're sitting basically it's like you're standing at a computer terminal. There's a computer here and the same instruments here to move your hands around, and then you wear 3D glasses. So they're saying this is better because you have open communication with your team. You're not sticking your head into a console. At the meeting, the instruments are very similar to the intuitive robot, and the surgery is basically the same surgery. It's just there are some benefits in that. Anyway, we don't know which one is better, but side by side, they had side-by-side surgery at this meeting. One was using the Hugo and this robot. The other was using the Da Vinci. They were doing the exact same procedure. So I don't know which this is going to be of any benefit, but it does come in at a lower price point. But one of the benefits to this is that the instruments that we use are usually they're used 10 times. You have a grasper, you have a scissor, you have a bipolar energy source. And each of those arms, those instruments are used 10 times, and then they got to be thrown away. So this one, the instruments, the scissors particularly, they're one-time use, you throw them away, so they're always sharp. But what time is it? This just shows the console you send in with the Hugo. And it's basically very similar to the Da Vinci, except you're looking at a flat screen with a 3D glasses. So usually, I told you I'm not a great speaker, but I'm trying to get through this. Focal treatment is not mainstay because obviously usually it's a prostate cancer is a multifocal disease, but obviously there are patients out there that do not want to have the side effects of erectile dysfunction or stress incontinence or any leakage at all. So they seek treatment where they can just have part of their prostate treated, which is completely reasonable. It can be done, and it is done, and to be a candidate for that, these days with biopsies that we do for prostates, MRI biopsies, we'll typically do like between 20 and 30 biopsies sometimes. And if those biopsies show that you have cancer just in one focal area of the prostate, then you could certainly have just that part of the prostate treated, but you need to be closely followed by your urologist afterwards because it's very, very possible, over 50% chance that you'll need to have the prostate treated again later in that area. I never was really very excited about this, but I recently went to a course and I watched some cases of HIFU, which is high intensity focused ultrasound, which basically is where you put a transrectal probe into the rectum. We look at the prostate and you focus high intensity ultrasound. And you basically superheat the area, just the area of the cancer is to treat the cancer. The old machines, the data was not very good, but there's a new machine called Focal One, which is actually the technology for this is amazing. This whole machine, by the way, which costs $750,000. If there's any donor out there that wants to give us $750,000, we could offer this here at Eisenhower. But it's got this transrectal probe and it's connected to this robot basically that has a screen. And what it actually does, it'll take your MRI images, it'll take your biopsy findings, and the live ultrasound is used, and we can actually map out on the screen exactly where your cancer is on the machine, both by the MRI and the biopsy data. The urologist, we put it all in there, the MRI data is brought in, and this thing will treat just that area very accurately, and it works really well. Like people, I think 5 years out, there's only been like a 4% retreatment rate so far for appropriate candidates. So this actually works really well. You just have to be followed. This technology is actually absolutely amazing. This is a video, it was supposed to be a video. But anyway, basically shows this is the transrectal probe in the rectum. This is the prostate. Oh, there you go. Yeah, it just sort of, what we'll do is we'll hit the target area and about a centimeter around it usually, where the cancer is, to basically superheat the prostate. It actually liquefies the prostate tissue. So you'll actually see it cavitate. You'll see this area where usually you can see you can see clear prostate tissue on the ultrasound machine as you're doing it. And you can actually change the urologist has the power to watch it and to move where you want to have it put during the treatment. You can actually see it cavitate and it could just turn black, which means there's no tissue there at all. So it's pretty amazing. There are places, most of the university medical centers are doing this, or have this machine and are doing it. So patients, we try to talk people out of this still, but some patients that really want to have it done, it can be done. You just have to be followed very closely. And so before that, so this just shows like low risk patients are here. Here's the intermediate risk patients, high risk. So focal treatment would sort of fit in those people. Like some people who have low risk prostate cancer, even though we tell you you're not going to die of prostate cancer, don't worry about it. There's still, if there's some anxiety, and some people still want to be treated anyway. So they would be outstanding. If they want to do something, they could do focal treatment with HIFU. Or if you're intermediate risk and you're favorable, and you can also qualify for active surveillance, then I would think about it. Going much higher than that, it's more risky, but that's sort of where I find this focal treatment falling. And then from intermediate risk, sort of middle of the road to high risk is where we think about doing either surgery or radiation. So sorry, I rushed through that and my voice is cracky, but anybody have any questions?
Thank you for coming. I will, Dr. Ahmad, I will just try to focus on the medical management of the prostate cancer. And I think my voice is okay. So I don't do cutting. I don't do any surgeries. When you say medical oncologists, we basically help with fighting the cancer with medications. So I'll try to go over basically briefly about multiple treatment options and how we think about it and how we tailor the treatment to fit the specific person and the specific situation. So I'll try to focus today on the advanced cancer, which is meaning metastatic, and metastasis means technically that the cancer has spread to other organs. So that's what we mean by the word metastasis. If you see, usually the prostate cancer will spread to organs, most commonly bones, and sometimes liver, lung, or even brain, which is very rare. And some terms, just to understand, when we go through the slides, we talk about castrate sensitive or castrate resistant. So that's usually what is the level of testosterone, because we'll talk about medications to lower the testosterone. So when we say sensitive, meaning that testosterone is still normal range. When we say resistant, meaning the prostate cancer does not respond to blocking the hormones anymore. And the testosterone is low, but the PSA is going up. So as of symptoms, when we talk about advanced cancers, it's basically there is no specific symptoms, unfortunately, for all cancers, most commonly, and that's why a lot of times we have a patients present with advanced cancers. And but the symptoms could be really basically depending on where the cancer spread to, and most commonly maybe bone pain, fatigue, weight loss, and some urinary symptoms. Or maybe nothing, that's just incidental finding on a patient seeing a doctor for something else and they do scan or a blood test that showed cancer. So what we usually do to look up if the cancer has spread or advanced, so I'm mainly focused again as advanced. Dr. Hendricks touched base mainly on the localized, or meaning that it is limited to the prostate area. We do a scan, which is including a CT scan or a bone scan, and now we have more better imagings that we called PSMA scan that we'll talk about it too. So when we see something on the scan, we definitely always need a biopsy, either from the prostate or from another place where the cancer spread to confirm that this is prostate cancer and it's not a different type of cancer, so we know how to treat exactly and what is the exact stage it is. The main thing really to treat the prostate cancer, as we say, is it's most commonly as if it is spread, or even when it is localized, a lot of times we need to lower the testosterone level. The reason is because the prostate cancer cells are fed by androgens, which is the main one is the testosterone. So we'll have to really lower that number because it feeds the cancer cells. And we'll touch base on this treatment options to talk about it. Most commonly, if the cancer has spread, that means, you will likely need some type of this medications all the time. But if it is localized to the prostate and you had surgery or radiation for it, most commonly it is shorter time. So the goal when we talk about advanced cancer or metastatic cancer in any type really is to control the cancer growth and make patients live longer, and to take care of the symptoms that they have from the cancer itself or from the medications. And of course, we don't want to extend lives but make patients miserable. So there's a big focus here on the quality of life and how we will always meet and adjust and talk about what could be done to make the life easier in all aspects. So when we talk about the hormonal therapies, that can be pills or shots that technically lower the testosterone production, and it can be done by orchiectomy also, but it's very rare now. Whenever you talk about it, patient gets sick. What are you talking about? I guess most patients would prefer medical treatment to lower the testosterone. other than taking the testicles out. So if we talk about systemic treatment, once the cancer is spread, it's again mainly medication treatment, and that's usually given by pills or in the veins or shots, meaning technically it's a medication that goes all over the body to help fight the cancer and control it. One of the most common things that I sometimes tell my friends, be careful about how much you support your wife when she goes through menopause, because you never know, if you develop prostate cancer, she has to be supportive, you will have the same symptoms. So if we talk about really the symptoms, that we make it easy, we say menopause. So technically, you will have some erectile dysfunction and loss of sexual desire, hot flashes, and gynecomastia, basically enlargement in the breasts, some mood changes, and on the long term, it's the main thing is it can cause weight gain and muscle loss. It can weaken the bones, which we call it osteopenia and osteoporosis. So that's something that we always watch and look into it too. So there's multiple ways of lowering the testosterone. One of them is really, as we said, to take a bilateral orchiectomy, which is meaning surgical intervention to remove the testicles. There is different other ways of shots or pills to lower it. And they are basically, for the most part, similar. Maybe some of them are a little bit better than others, but they all work on lowering the testosterone. Most of the symptoms happen from lowering the testosterone. In addition to that, now for advanced cancer, we don't only do that anymore. Now we're becoming into intervening more and more, as much as we can sooner, because we know by studies that patients live longer the more we do initially. And of course, again, we always focus on the quality and what fits that exact patient. So if we add to the blocking if we add to the lowering the testosterone to below 50, we always add a medication to either lower testosterone production from other organs or to prevent whatever left from possibly testosterone on the cancer cells. One of those is what we call them androgen receptor inhibitors. We have a lot of old medications that we don't usually use anymore. More commonly now, we have multiple oral medications that work in that direction, including apalutamide, darolutamide, and enzalutamide. I would say generally, because we treat most cancers roughly, the prostate cancer systemic therapy or management is a lot easier than most common cancers. And those treatments are, although they are listed could have major medical issues from them, but most commonly patient will have very reasonable quality of life, and they live a lot longer than other type of cancers when we mainly do chemotherapies. So those medications are definitely making a big effect, positive effect on better quality of life and longer survival. Some of these common side effects from these medications could be really feeling tired, dizzy, and diarrhea and rash, and rarely some of them can cause seizures or mental changes. All of those really you have to be done by a medical oncologist generally, and you have to be watched. That's why we meet every few weeks, if not every few months or couple months, if not every few weeks, sometimes depending on the specific patient and how do they feel. The other way really is to block or stop the cancer from getting worse, is to stop the cells from making testosterone. And that's a different medication that we call Zytiga. That's also a pill that we give with prednisone to decrease the possible side effects that can happen from Zytiga. Those also can cause some nausea, diarrhea, and some heart issues. So we always try to avoid those if a patient has major cardiac or heart issues. And again, we watch the patients closely for all of possible issues that could arise. They can cause liver problems, so we watch the liver enzymes with that too. more and more we're becoming more sophisticated, and I think yes, once we get better and better, things get more complicated and complex. So nowadays we always test the cancer cells for more targeted therapies. That is meaning if we find something on the cancer cells that we could target directly, and some of those medications like olaparib or other PARP inhibitors can be used in some of patients, but generally those are not everybody is eligible for those. A small part of prostate cancer could be also genetic predisposition. So now the guidelines is definitely recommending that we test everybody for any genetic predisposition, such as BRCA mutation, or I always make it easy for the patient, and Jelena-Jolie mutation that you have to do mastectomy and all of that. So the same gene can affect male also that predispose them to prostate cancer. And in some of those, definitely we have more treatment options and usually a lot easier treatment options. So we always definitely recommend doing genetic testing for any patient with at least moderate risk, what Dr. Hendricks just mentioned now, and definitely in the metastatic setting when they present with metastasis. The main, most commonly most difficult is generally is the chemotherapy. That is the usual what used to be most commonly. Now I would say really most patients will go through all of these treatment options. So it is that it's how, or most of the treatment options, it's really how the patient specifics and how we incorporate that. So most patients will go through few of those. You start one and then you see how they do, and then you start the other one if the cancer gets worse. But I would say technically the chemo is the most difficult one, which is giving in the veins. It's every few weeks, and we have patient has to be watched closely. Those can cause more fatigues and lower blood numbers and nausea and affect other organs, and there is risk for developing infections also. So usually we give a shot to prevent white blood cells from dropping. There is more and more about immunotherapy also. I mean, there is some old type of immunotherapy medications that we use, and there is newer ones, and that also depends on the specific per patient. What do they have? What is the extent of the disease and how many organs it is? So it's definitely can be, the treatment can be different from one patient to another. And sometimes, you know, you get heard, oh, my neighbor or some relatives got this, but that doesn't mean you are the same person and the sequencing will be the same. So it's always definitely to have a good team and good connection with your doctor to discuss what are the options and then choose between them that basically fits you. That's the best way to go. If we talk about some of these options, what we talk about Provenge is basically, you know, you take blood from each patient through leukapheresis, what we call it, and then they tailor it to attack to your cancer cells, and then they infuse it back to the patient. The other option is what we call it Zofigo, which is also a radioactive substance that also goes to target cancer cells, especially if it gets worse after initial treatments. The newest, or the most commonly newest now that we would say that we use, which is called Pluvicto. That is usually what we do, the scan that we call it PSMA, and the PSMA means prostate specific membrane antigen. So we do a scan and we see how spread that cancer is. And once it gets to a certain level, then this can be given to the patient, and they have to be watched with their blood numbers. Usually it is reasonably tolerated. It can still lower the blood numbers and cause dry mouth and nausea and anemia. We always have different levels of acceptance, even by insurances. So we cannot jump from the get-go, initially when we see patients to do this. I mean, definitely there's more trials and trials looking into bringing the later agents to the sooner area, but this technically can be done after patient got worse on couple options, not as the initial treatment. With those, because the treatment can affect the bone health, as we mentioned, and it can spread to the bones. We are always worried about bone fractures. So we always give medications to strengthen the bones, and the backbone of those is the same medications that we use for osteoporosis. There's multiple compounds, either given a shot or a pill or an infusion, and those mainly usually very easy. However, sometimes rarely they can cause some what we call a jaw necrosis. So we always advise for a good dental health, and we have to hold it or change it around any time of dental procedures or surgery. So usually most of treatments for prostate cancer, once you start the medical treatment for advanced cancer, you have to continue until um, either the patient cannot take it anymore or the cancer is getting worse. And we usually don't do all the time scans unless the patient has issues. But we may do that if the PSA kept going up or the patient developed have new issues. This goes on, and usually patient, at least for the lowering the testosterone, this has to be all the time in the when the cancer is spread. We always need help from other subspecialties. So generally, we a lot of times need, especially when the cancer spread, you need help from pain management, from palliative care doctors. We always need nutritional support, social support. So, and that's the good thing about having a really good team or multidisciplinary team that can help in all aspects, because we don't want to get lost on focusing only on the medical part. We want to treat you as a whole person and support you through all of aspects while you're going through cancer treatment. So I'll just say, just to remember, basically to say, hey, still metastatic prostate cancer is treatable and patients live years and years with that. We do all have some backgrounds about relatives or family members who have been through treatments, life changed. I always say, don't rush to make decisions, always discuss. Now we have Tesla. We didn't have Tesla 15 years ago, I guess, or so things changing. Same way as the cancer treatment, that life is getting easier, or for the most part, in some aspects, including cancer treatment. There's multiple treatment options, and always, you have to give a good discussion about what can fit you and what may not fit somebody else. And of course, the research is ongoing to improve the outcomes and what we're looking for. And I think we are making good progresses in the area for sure. And just to emphasize that also we reached here what we know about prostate cancer through going through clinical trials. We wouldn't have all of these options without having clinical trials in the past, and we have some that we always encourage. We have some new ones here if you want to look. I think for the prostate, not so many, but we still have definitely. You could look it online at the Eisenhower website, or also we have a new trial here for newly diagnosed patients with prostate cancer that adds the chemotherapy to a pill type of of aplutamide, if I would be specific about it. We are connected also with NCI, and we have trials with them too, and we also partner with UCSD for some clinical trials and tumor boards. So if whenever we have some challenges, they are very helpful, and we always sometimes have more support from them even through trials. And with that, I think I'm done. I'm happy to answer any question. And most commonly, it is very slow growing cancer. So that's usually making it easier for the radiation oncologist to treat you. I think Dr. Patel would touch on that, but I wouldn't worry about it. If your PSA came down, there is no rush for time. I always like to be on top of things in the exact times, but I wouldn't worry waiting also.
Wow, it is quite the turnout. Great job, everyone. And thank you for your time. I'm Dr. Patel. I'm a radiation oncologist. It's a field that very few people understand, including even people in healthcare. It's a field that constantly is changing. And I think what you guys will find is there's a lot of synergy between our discussions, the ones that have already happened and the ones that will happen. And my talk is just going to be on updates. This whole symposium could be radiation oncology because there's a lot of topics we could discuss, but it's going to be small sections of radiation oncology. And then we're happy to give a more full symposium if there's interest as well. So, I'm supposed to go to the next slide. So the big emphasis in oncology over the last 30 years has been a great shift. And kind of what Dr. Ahmad alluded to, kind of like you guys probably remember what cell phones were like in the 80s and 90s and how they are now. And that's how much healthcare has advanced and how quickly everything's advancing. So for a physician, it's a wonderful time to be in healthcare because there's an incredible amount of advancements. The issue is they come at such a rapid pace that it's sometimes hard to keep up. But one of the big emphasis, and I think critically important, is up until about 20 years ago, our full focus used to be on trying to get a treatment response from the cancer. And I think as treatments have advanced, we've fortunately been able to get a wonderful response. And then we realized that, these patients live a long time, but now they're dealing with the consequences of the treatment that we delivered. And so really our focus for the last 20, 30 years has been trying to maximize effectiveness and maximize long-term quality of life. So there's a lot of advancements Dr. Hendricks talked about, Dr. Ahmad, and some that I'll talk about as well that really help us maximize both for each patient. And we'll just start with talk on localized prostate cancer. This is one that hasn't spread. And this is a very busy slide, but basically there was a study in the UK that compared for localized prostate cancer patients, radiation, surgery, active surveillance, and they thought that all of them were fine. And that's kind of what Dr. Hendricks alluded to. They all have kind of different benefits and disadvantages, but typically in the United States for early stage or locally advanced prostate cancer, the treatment choices are surgery and radiation. And for my field, there's kind of 3 buckets or categories of how radiation is delivered. There's external beam radiation, which we're going to talk about, and this is kind of what the machine looks like. There's brachytherapy. There's 2 different types. There's seeds, and then there's a high dose, and I have a decade of experience doing both of those. It's not something I currently do or we currently offer, and there's a exciting field, and Dr. Ahmad alluded to it, theranostics or radioligand therapy, and we'll talk more about that as well. So just to begin with external beam radiation, over the last 40, 50 years, there's been incredible advancement in radiation oncology, and I'm gonna show you visually kind of what those advancements are. So here is the 1960s and 70s, where we used to do what we call 2D radiation. And it's called 2D because there weren't CT scanners. There wasn't a way to image patients to see what their cancer looked like. So what we used to do are clinical exams. We'd actually touch patients and try to figure out where their cancer was and then estimate where the treatment should go. But that had a lot of disadvantages. So what we used to do is so unfortunately in this slide, it's hard to see, but the prostate is right here in the middle. So the bladder is yellow. That's the prostate that we're trying to treat, and that's the rectum. And so what we used to do is just have a field come from the front and the back. And that was somewhat effective, but we were limited in dose, and that treated a lot of tissue that we didn't want to treat. And then CT scanners came to be. And then we started utilizing CT scanners so we could do something called 3-dimensional radiotherapy. And with that, patients got scans. We were able to draw where we want the radiation to go and draw things we want to avoid. And with that, we're able to do much more pinpoint radiation. So this is a classic 7-field radiotherapy. And our volume got much more pinpoint. And it's still a great way to treat certain cancers like breast cancer, early stage. It's still a great way to treat it. In the 90s, they developed something called multi-leaf collimators. And nowadays, we do a lot of something called intensity modulated radiation therapy. And so if you ever look at a LINAC, our linear accelerator, if you look at the head of the LINAC where the radiation comes out of, this is what the collimators look like. They're tungsten lead blocks that can basically form different shapes. So including like a heart shape. And what can we do with those MLCs, those multi-leaf collimators? We can do intensity modulation. And so for that same prostate patient, now we're able to do even much more pinpoint radiation. So that was still about 20 years ago. And since then, we've continued to advance. So just a brief recap from the 60s, 70s to the 80s, 90s to 2000. And now we have something called triggered imaging, real-time tracking. And you guys will get to see what that is in just a little bit. Why have we been able to do these advancements? Certainly hardware has a lot to do with it. Software has been equally important for us. But the most critical component is always the expertise of the person using that equipment. So you need the right expertise to be able to optimize that hardware and software. And there's certain accessories that will show that have really helped, especially for prostate patients. So how do these help us? And basically how they help us is they help us improve cancer control, decrease side effects, improve long-term quality of life. And in red here, it shows you grade 3 rectal bleeding from the 2D days where about a third of the patients would have long-term rectal bleeding to nowadays where typically less than 5%, usually 1% would have long-term rectal bleeding. And that's because of all the advancements that I just mentioned to you guys. So one of the things my colleagues help do are place these fiducial markers, and we'll show why they're important. But that's kind of what they look like, and our urologists place them in the prostate for the radiation. There's also something called rectal spacer, and that's this thing right between the prostate and the rectum. And basically, it helps to push the rectum back out of our high-dose radiation field. And so we have national guidelines on how to treat curative cancers. And in terms of national guidelines, what are the different options that are offered for prostate patients? And certainly for external radiation, the classic 8 to 9 weeks, which we've been doing for over 20 years, is still considered appropriate. And in certain patients, it may be the best option. But then they've looked at different studies as our radiations become more pinpoint. We've asked, hey, can we do the same thing in shorter time frame? And the answer is yes, we are able to do the same treatment in shorter time frame. So we can do 6 weeks, we can do 4 weeks, and we can do 2 weeks, this SBRT or SABR. It's actually just 5 treatments and they're done. And here's kind of an article showing that in this one, at least over 6,000 patients treated with this 5 treatment, their cure rate, success rate was excellent, comparable to anything else that we offer. And the long-term rates of toxicity, both peeing or pooping, were extremely low in this study, 2% and 1%. So it's actually probably the main reason why I switched from doing a lot of brachytherapy to doing this treatment for patients. If you look and see kind of the way brachytherapy is done and patient tolerance, at least in my personal preference, in my personal opinion, this has turned out much better for patient care and quality. So how do we do that? So SBRT or SABR. So this is where it's very important for us. Once the patient gets on our radiation table, we really need to know that they're aligned appropriately and for the duration of treatment. So what you see here are x-rays that we take right before we treat prostate patients. And those are the fiducial markers that I showed you our urology colleagues place right before we start. And our machines also have a CT scanner built right into them. So we also do a CT scan and align right to the prostate. And once we feel that everything's set up pinpoint accurate, we're ready to treat. So what you'll see here on the next few slides is this radiation machine, it's actually going to go around the patient. And as it goes around the patient, there's actually software that keeps track of the prostate. And if for some reason the prostate moves even a little bit, the machine will automatically turn off. Then we'll assess why there was a shift in the movement of the prostate. We'll set the patient back up and we'll be able to continue. But as it continues, you can see, that all of these circles are green. If the prostate were to move, it would turn yellow or red, and then it would automatically stop. So that really helps us deliver this 8-9 weeks of treatment in 5 treatments with significantly minimal long-term outcome side effects. We always get asked protons, and I think sometimes patients come to us very excited about proton therapy, thinking it's the latest and greatest. And protons actually have been around since the 90s. And on paper, they are absolutely fantastic. And it's still kind of a puzzle to me why they didn't take over. But the issue is the theoretical advantage that protons have never translated to a clinical benefit. And so for whatever reason, there's a lot of reasons which we could spend a whole hour on. The outcomes between proton radiation and IMRT X-ray radiation that we've been talking about, the tumor control, side effects, quality of life, they're all the same. So here's a recent study that kind of says the same thing. So unfortunately, there's not a significant or any advantage of proton radiation over X-ray radiation. We are affiliated with UCSD. We actually work very closely with the radiation oncology department, and they do have proton services available. So we're happy to make that referral and get you guys over there if that's something that's of interest. I do speak with the proton team, with the UCSD team. All of our physicians actually have a lot of close relationships with the UCSD team over there. And so we're happy to connect our patients as well. But as of today, no benefit. So this is a study where patients are always worried about erectile dysfunction. So looks like surgery, radiation, the outcomes are pretty much the same. This data is old data, and obviously things, as I just showed you, have advanced significantly. The problem with data is by the time you capture it, it's 5 or 10 years old technology that you're utilizing. So to get real-time data, it's hard to do. There is something called oligometastatic disease. And for my field, we've seen significant increase in referrals for that. And the next few slides just kind of discuss what are these situations and why do we treat them. So in the 90s, there were 2 physicians that created this theory that not all patients with metastatic disease are the same. And there might be a certain portion of patients that may be curable or have long-term durable response to treatment if caught early enough. And those are patients with oligometastatic disease. And so what we used to think is there's 2 states of cancer, localized curable and metastatic uncurable. And these 2 physicians, they're like, no, there's actually a 3rd state. So localized curable, widely metastatic, still thought to be uncurable. And then these oligometastatic patients. So these are patients who have 1 to 5 sites of metastases. And those patients we used to think were incurable, but every day the data keeps building up and up and up that if they have a response to systemic therapy, a treatment Dr. Ahmad would do, then actually local treatment is extremely important and we might be able to achieve long-term success. So these are patients we see quite a bit nowadays. So here's a study that showed actually this was the big first study that showed that local treatment, and sometimes local treatment actually is surgery. So for certain other cancers, surgery might be the local treatment, but in most cases it'll be radiation treatment, and specifically we typically do SBRT for these patients. And finally, something that's very big and exciting, something relatively new, is something called radioligand therapy. And I'm just going to try to explain what it is and how we deliver that treatment. So Dr. Ahmad alluded to this a little bit earlier, but radioligand therapy has two components. So there's a tumor-seeking molecule and then a radioisotope. So let me show you in this slide what that means. So here's a cancer that we want to treat and kill, and it has this door, and we need the right key to get into the cancer cell. So that's that ligand, and the ligand is the key. And when we attach it, we can actually see stuff. We can actually see the cancer, right? So that's that PSMA scan that Dr. Ahmad mentioned. So that's what the PSMA scan is we have a key to see where those cancer cells are. And that's great, that gives you imaging. But the next part is, what if we actually attached a radiation particle to that key? Then it'll go right to the cancer cell. And so that's radioligand therapy. And the biggest, best known one, especially for prostate cancer, is Pluvicto. So here's Pluvicto, and basically what Dr. Ahmad mentioned, that on the surface of prostate cancer cells should be these prostate-specific membrane antigens. And some healthy cells have it as well, but mostly it's on prostate cancer. And so we can attach Pluvicto to it, and Pluvicto should attack and kill those cancer cells. And that's what the study shows. That is something UCSD does offer, and that's something we're happy to get our patients over to. And that was my talk. Thank you guys for staying awake. I'm happy to take questions as well. Yes, sir. I can. So the brachytherapy versus other options, really that's the hour-long personal discussion with the patient about what's appropriate for them. And typically for early stage, so the localized prostate cancer is broken up into low, intermediate, high risk, and for low to intermediate risk, brachytherapy by itself would be considered standard of care, but alternatively, you would have external radiation or surgery as the standard of care. And exactly what metrics you use, that depends on the patient's situation. So there will be a fairly long discussion, but it's based on the prostate volume, their urinary function, their history, if there's any genetic components, their Gleason score, and so forth. It depends. So he asked if is brachytherapy a one-shot deal. The seeds are a one-shot deal. Alternative to seeds, which is low dose, is something called high-dose rate brachytherapy. And typically high-dose rate brachytherapy is multiple treatments given maybe once or maybe over a period of a month or so. It depends on which site you go to and what their protocols are.
Dr. Patel, could you go back one slide for this question, please?
Sure.
One
Further back? Well, I think it's because of the top thing you see. It says, so radiographically, meaning on imaging, there was a significant delay in progression, meaning the cancer didn't continue to grow. So yes, you would think simply that overall survival would be the best evaluator and maybe the only metric we should use. But typically when you look at studies, the the details of the studies and exactly what metrics are being used change from study to study. And uh, sometimes it's hard to see that survival benefit. And it could be for a variety of reasons. One, yes, maybe there's no survival benefit from the treatment. Or two, it's the results are published too early. And if you wait longer, then you're going to see that survival benefit. So there's here are the reasons why it may not show it now. But it is important for patients to know. But does it provide value in certain subset of patients? Yes.
Thank you, Dr. Patel.
Hi, everyone. My name is Willie. I'm a pelvic floor, pelvic health therapist here at Eisenhower. Today, we're going to talk about something simple but powerful, how pelvic health therapy can help men recover from prostate cancer treatments. And so I am a physical therapist, so I want everyone to stand up for a second, get some circulation in your legs. Thank you. And, you know, march in place. If you hold on to the back of your chair, if you have good balance. Kind of stretch your hips. Okay, awesome. 5 minutes? I don't, yeah. All right, awesome. Thank you. All right, so prostate cancer, there's about 1.5 million global new diagnoses a year. So it is pretty common. And with some of the prostate cancer treatments, urinary incontinence or erectile dysfunction, some of those side effects can occur, you know, up to some studies show 80%, but with the newer technology, I think it's definitely decreasing. But still, those things can affect the quality of life, and pelvic health therapy is something that can help get recovery sooner. So what exactly is the pelvic floor? They are a series of muscles, ligaments, nerves, and they are part of your functional core alongside the diaphragm, back muscles, and abdominals. So the pelvic floor supports bladder, bowel, and sexual functioning. So we can take a look at the male pelvic floor anatomy. From this angle, you can see that these muscles kind of span from the base of the penis, sling around to the rectum. They attach from the pubic bone to the coccyx or tailbone, and in between the sit bones. And here you can take a look at the relationship between the pelvic floor, which is kind of like a hammock or a sling at the base of the pelvis, alongside the relationship with the bladder, prostate, and rectum. So what does pelvic health or pelvic floor therapy do? It's a specialization within physical therapy. We focus on rehabbing people who've undergone or anticipate pelvic surgery or radiation treatments. We treat pelvic organ prolapses or gender-affirming care procedures. Now, prehabilitation is initiating physical therapy prior to the operation in hopes of hastening and enhancing post-operative recovery. So that's kind of emerging, getting into PT beforehand. Pelvic floor therapy focuses on rehab of the levator ani muscles, which function to elevate the anus. And again, they're a set of superficial and deep muscles, ligaments, and endopelvic fascia. So what kind of symptoms would someone have if they had pelvic floor dysfunction, bladder or bowel incontinence, pelvic or perineal pain, pelvic organ prolapse, vaginal or rectal, sexual dysfunction, so pain with intercourse, erectile dysfunction, ejaculatory dysfunctions, abdominal pelvic pain, and gastrointestinal dysfunctions as well. What kind of treatments do we do? Well, we target the pelvic floor muscles to restore continence and function after prostate cancer treatment. So we can employ using quick contractions of the pelvic floor that help with urgency as well as stress incontinence. So a lot of men might have leakage when they're coughing, sneezing, standing, or lifting anything heavy. And we focus on building endurance of the muscles as well, and that'll help you hold your bladder for longer. We also use biofeedback. We use electromyography here at our clinic, or some other clinics use pressure sensors, and that provides real-time feedback. So you can see in this picture here, a patient is undergoing biofeedback training, and you can see on the monitor that there's the microvolts of muscle activation down there. We also use manual techniques, myofascial release, to address increased muscle tone, tightness, and spasms. So there's a lot of evidence supporting post-operative pelvic floor therapy. Pre-operative treatment still needs further studies. The American Urological Association grades the preoperative training as level C. However, newer studies show that it can reduce pad use earlier post-prostatectomy at 3 months. Now, baseline musculoskeletal and cardiopulmonary issues are also contributing to weak pelvic floor muscle function, fatigue, and reduced mobility after surgery. So if we can address the muscle strength and cardio, that might yield better results. So with pelvic floor therapy, we focus on muscle training, global strengthening, including the hip, the core, lower extremities, and provide education. So typically it'll take 4 to 6 weeks to see strength changes for neuromuscular changes, and around 6 to 10 weeks to see actual muscle growth. So I tell patients it's like going to the gym. You have to be consistent with things, and it will take a while to notice anything functionally. And so, yes, sometimes after a radical prostatectomy, patients will experience a reduction in physical function, urinary incontinence, erectile function, and fatigue, which may result in a decreased quality of life that can last 6 to 12 months or even indefinitely. But a comprehensive preoperative intervention may include a structured exercise program, maximization of nutritional intake, so making sure you're getting sufficient protein in, and drinking adequate amounts of water. A lot of patients will refrain from drinking water because they don't want to leak as much, but sometimes that can, that makes the urine more concentrated, and that can be irritating to the urethra. Psychological support is also important. Eisenhower has a great prostate support group. So a lot of men might not feel comfortable speaking about these kind of conditions. So it's great to be around folks who've experienced the same things. And then cessation of negative behaviors, maybe avoiding drinking too many bladder irritants like coffee, alcohol, or acidic beverages, which can irritate the bladder. And generally, it's been found that undergoing aerobic training 3 times a week, 4 to 6 weeks before abdominal surgery, can reduce post-operative complications. Pelvic floor muscle training uses both coordinating the smooth and skeletal muscles of the pelvic floor with varied intensity and volume to enhance strength, power, endurance, and coordination. And yeah, we target deep abdominal muscles, the hip muscles, and weakness or poor coordination in them can contribute to pelvic floor dysfunction and an increased fall risk. So generally, the stronger you are in your legs and lower extremity, the stronger your pelvic floor is as well. A combined approach of pelvic floor muscle training and core training has been found to improve urinary incontinence and quality of life, and may further support pelvic floor function. So I like to have patients kind of progress and start doing kind of like Pilates type motions to kind of co-activate the abdominals, the diaphragm, and the pelvic floor. We provide education on postoperative changes, expectations, recovery timelines, and rehab is key for mental readiness. We provide clear guidance, which can ease fears and reduce preoperative anxiety, as well as counseling on behavioral and self-management strategies. Time voiding, so scheduling out how frequently you're going to the restroom to help retrain the bladder, hold a higher volume is another thing we work on. And voiding methods that supports use supportive postures. So we want to avoid any straining postoperatively or in general. Promote relaxation and use breath work. So a lot of diaphragmatic breathing. We also want to make sure you're maintaining bowel regularity because that bowel does sit next to the bladder in order to reduce pressure on the pelvic floor. So for prehabilitation, initiating physical therapy prior to operative treatments has been shown to reduce postoperative urinary incontinence or leakage by about 50% at the 3-month mark, and continued reductions occurred from 3 to 12 months. Another study showed that, at 3 months, at the 3-month mark, there was improved incontinence. In terms of initiating therapy after the prostatectomy, the rehab can begin 1 to 4 weeks post radical prostatectomy or radiotherapy. We use progressive pelvic floor muscle training to restore the continence. And it's been shown to improve the quality of life with patients, significantly reducing pad weight test. So that's measuring how much urine you lose in your pad and you weigh it. And that's one way to track how much you're losing throughout the day or during certain activities. So they showed some benefits there, as well as enhancing, the recovery just quicker. How do the pelvic floor muscles affect erectile function? So they manage blood flow to the genitals by compressing the penile veins, thereby trapping blood in the penis, creating an erection. If the pelvic floor is weak, the outflow of blood isn't prevented and an erection can't be maintained. So a pelvic floor that is too tight is also a possible cause of erectile dysfunction due to compression of the arteries that supply blood to the chambers of the penis. For physical therapy for erectile dysfunction, there's kind of mixed studies for preoperative or prehab, but there's a lot more evidence supporting its use after a prostatectomy, especially when paired with a PDE5 inhibitor, so like Viagra or Cialis, or a vacuum device post-prostatectomy. And it's been shown that a higher intensity of pelvic floor muscle training, about 6 sets of contractions per day, promoted faster ED recovery and higher IIEF, International Index of Erectile Function scores, at 12 weeks. So at Dolores Hope, we do offer a multi-specialty clinic. We offer therapy for pelvic health, oncology, and neurology. So if you are facing any of this or a combination of these, we do have therapists that can help you. And we have 3 locations. So whatever is closer to you and more convenient, we just need like a physician referral, and we do accept most insurances. So yeah. Thank you. Any questions?
Okay. All right. Can everybody hear me? I think I'll get hidden behind the podium, so I'll stand up front. So I'm Ryan Nasseri. I'm one of the faculty at UC San Diego with a focus on male sexual medicine, infertility, men's health, and testosterone. So I have no disclosures today. Today, I kind of just want to talk about what is the impact of prostate cancer and its treatments on sexual function. What do we do about it from a rehabilitation standpoint? What are some rehab protocols that I like to put patients on? And then what are some more extensive treatment options? I always tell patients, I can always find a way to make sure that you can get an erection after surgery. It's just how far do you want to go in order to get there? So just after radical prostatectomy, radiation, as Dr. Patel also showed, you know, the outcomes long-term are fairly similar, and I think there's a few reasons. Number one, we know that age 40, about 40% of men have erectile dysfunction, and it goes up about 10% per decade of life. So men in their 70s, you know, more chances than not, there's some element of erectile dysfunction. And now we've added an insult to the system. And so when we talk about 5, 6, 7 years out from prostatectomy, you know, you're also fighting time as well, not just what was done to you. So what we typically see in the things that happen are fibrosis, meaning scar tissue buildup or less elasticity of the tissues required to get a good, strong erection. And men often find that they have actually lost size over time, and that's a function of not getting strong erections, but also because of the fact that there's decreased blood flow. And then because of that, men who have undergone radiation and prostatectomies tend to be at higher risk of getting Peyronie's disease after treatment as well, which can be, you know, frustrating and warrant additional treatments. So this, you know, just looking, you know, being able to get an erection sufficient for intercourse over time after treatments, you know, kind of just looking at a bunch of different papers. Like I said, this isn't necessarily all because of treatments, and a lot of it also has to do with the fact that we are fighting time as we get out from these treatments as well. So what do we want to do? I think the main thing is what do you want out of your function after treatment? You know, not included in my talk today, but it is something that I do suggest to many people is, you know, if they feel that they're not wanting to go through surgeries or they just feel treatment out because there's, you know, they're gone through so much already with their cancer that they don't necessarily want more medications, more aggressive therapies, more surgery. I usually do recommend patients talk to an intimacy counselor if that's something that is of interest, if they want to explore other avenues of intimacy to kind of recreate and regenerate their relationships. But essentially everything is at your pace. I never force anyone, and I can't force anyone, and I never try to talk anyone into something. I usually just present with options, and whatever aligns with your goals is what we go with. So after prostatectomy, you know, the main things that we want to do is we want to avoid that long-term fibrosis. We want to encourage good blood flow right after surgery. And the main thing about that is all of it was as you recover, you'll suffer from less of those consequences, lowered Peyronie's, a lower chance of losing size. And it's usually a combination of both. Rarely is it just medication that I give someone every day or tell them to take before intercourse. It's often medication, but I also do encourage men to use vacuum devices because of the fact that those vacuum devices essentially will improve blood flow, keep things expanded even when you're not getting those full erections, and help you recover out. So, you know, as it comes to the options though, there's always the oral pills. Everybody knows about Cialis, Viagra. There's a few others that have different acting qualities. The vacuum erection device, and then kind of the most aggressive for anything that's not surgical is injection therapy. And, you know, all of these potentially can be interchangeable or in combination. And, you know, sometimes we start people on, you know, they try medication, it's not working out. Well, we try injectable therapy, especially if they're only a few months out from surgery and they want to get back into things. And then as time goes on, men can continue to improve. As long as there's signs of improvement, I'm always encouraged to say that they will continue to improve for up to 2 years after treatments. So sometimes you may start here, but as time goes on, maybe you're able to regress back to just medication. Sometimes it goes from medication this way. We just do everything flexibly in order to fit whatever your goals are and what's working for you. So, when we talk about the pump, why do I think the pump is great? So there's a few things. Number one is, like we just talked about, size loss and the fibrosis are two main things that really drive a lot of the problems long term. And when you're not getting those erections, the way I liken it is a 20-year-old man, the penis of a 20-year-old man is like a bodybuilder going to the gym, 10 times a day. But by the time after a prostatectomy, it becomes kind of like a couch potato, unfortunately, for a period of time. And the pump is essentially that mechanism of going back and forcing or mimicking the erectile function again. Even if it's not adequate for intercourse, you're at least pushing things to that boundary so that when the time comes, it's still ready. Now, in guys who use it early on after treatment, up to 80% will say they can have successful intercourse with a combination of medication and the pump. And guys who just use the pump alone, about 20% will say they'll get spontaneous erections. But we do know that medication and a pump is better than a pump alone. The main part of this is I consider it kind of the physical therapy, of treatment for patients. Next, we have our options of injection therapy. So there's kind of 4 different categories of injections. One is a branded kind of formulation. It's just one medication called alprostadil, much more powerful than Viagra, Cialis. All of these are. But the kind of convenience of this for men is that it's prepackaged, so you don't have to do much work. It comes in a ready-to-go syringe that you just load and then inject the dose as you need. And it also has the lowest rate of priapism, which is an erection lasting too long, which unfortunately is an emergency. And it has high satisfaction for those reasons. Additionally, compared to all of these all have to be refrigerated and stored properly. This can be stored at room temperature fairly indefinitely. So for people who like to travel a lot, I actually really like to suggest this because it makes it a lot more convenient to travel with. These are just escalating, essentially just adding ingredients to this original alprostadil just to amplify the effects of kind of expanding the blood vessels, allowing more blood flow in. The effects of these are pretty fast, usually about 5 to 10 minute onset from use after injection, and they can last in some guys, it gives them anywhere window, depending on what the dose is, from 1 to 4 or 5 hours of use per injection. So it is a great option for men who are not initially responding to medication and who are willing to inject. It's fairly safe comparative to things like Viagra or Cialis. There are no systemic side effects to injections. With Cialis or Viagra, we talk about guys getting flushing, feeling lightheaded or dizzy, or kind of that chest fluttering feeling, or headaches, and that does not happen here. Really, the only side effects that happen are just bruising and pain from a needle. But the needle itself is an insulin needle, so it's a very small needle, very small syringe, and it's a great option. Now, when do we start all of these? Unfortunately, unlike our radiation and our surgery and all these other things, we don't have a guideline for this. But what we do know is that there's plenty of studies that show essentially the earlier, the better. So some people will start as soon as the catheter comes out, or some people will start their patients on Cialis, a daily Cialis, as soon as they're done out of the operating room, essentially. And as I talked about, as long as people are progressing, I don't usually encourage them to seek more and more radical therapies, because as long as you're getting better, then I have confidence that you're going to continue to get better. But the dailies that we were talking about is I have a strong preference for tadalafil over Viagra if someone's going to be taking a daily medication. And that's because, first of all, it lasts in your system for 24 to 36 hours. So it always leaves some in there, whereas Viagra is a quicker onset and out of the system within about 4 hours. Another thing, not shown here today, but another part is just this. We have recent studies that actually show that tadalafil exposure actually can lower your risk of heart attack and needing stents or just overall death. So I'm actually a big fan of this medication, and a lot of guys who are skeptical about it, I show them the studies, and they tend to be more happy to take them. Another option is what some people will say is that they can get an erection, but then it's fleeting, meaning they're able to get there, but then as soon as they're trying to be active, it just goes away. And one option for that is a constriction loop. I always recommend something elastic and that opens, but a constriction loop is a great option for men who are able to get to an erection but have a hard time keeping one. It essentially will just keep the blood flow there. It can decrease sensitivity a little bit, but it is still a great option. And then what about surgery? This is kind of where I specialize. On the left side here, this is what's known as a malleable penile prosthesis. The mechanics of it are fairly simple. It's a kind of a silicone or plastic exterior with a nitinol interior that's flexible. So essentially the length stays the same, the rigidity stays the same. What happens is when you are not in use, you essentially can bend it away from whatever direction you would want, whatever is comfortable for you. The beauty of this device is that pretty much once it goes in once, it has an unlimited lifespan, meaning that I rarely, if ever, have to replace one of these. It mechanically doesn't fail. It's got, I think the manufacturer says somewhere around 20,000 uses, which is quite a bit. And then the other part of it is that it doesn't require some of the dexterity kind of as the inflatable device would require. So people who have trouble with their hands or neuropathies, this is an excellent option. And actually in Europe, it's the more preferred option because it's what tends to be covered. Here in America, this actually tends to be the one that's implanted the most. This is the inflatable penile prosthetic. It's essentially designed, it's been in use for about 40 years, and it's essentially designed to mimic what you have inside your body, which is a hydraulic system. It has 3 components, 2 cylinders that go inside the penis and inflate where your blood would actually flow when you do get an erection. It has a reservoir to store all the fluid when you're not using it, and everything is tucked inside, not visible to anyone. Nobody will know that you have one just by looking at you. And then in the scrotum, right in front of the testicles or between, is a pump that essentially, as you pump it, moves fluid from this reservoir into the cylinders, and it just inflates until you have a good erection. The good part of this is that it does, comparative to malleable, it mimics more normally your normal anatomy. The downside is that it will last shorter. It has about an average of 7 to 10 years of life to it. At some point, one of these components will break down mechanically. So what can an implant do? The most important things that it does is that it restores your control, reliability, and spontaneity. When there's frustration with medications that work inconsistently, injection therapy can ruin some of that spontaneity. 5 to 10 minutes before intercourse, you have to go inject yourself, or just timing any medication an hour or two. It can be a lot of planning, and it can cause a lot of anxiety. And what we do know is, like I said, is that the malleable and this inflatable prosthetic do have fairly long lives for working. And the satisfaction rate is pretty high. Independently, outside of what the companies publish, we do know that 80 to 95% of patients and their partners are very happy with the devices. And we know that over 90% of men would say that they would have recommended it to somebody else in the same situation as them once they've had it. The surgery itself, it's a day surgery. 1 day of a catheter and sometimes a drain. And it's, a handful of weeks of healing. And then, at about 6 weeks, you're back to using the device as it's meant to be. But what an implant cannot do? I cannot take what you have. I cannot take you and put you back into your 30-year-old body, unfortunately. I can only do the best with where you are now. So it's all about maximizing where people are at that moment. I cannot increase size. If I could, I would probably be on the golf course retired by now. And I can't change your desire or interest. That's not what this device does. It's really all about restoring you back, maximizing what you have and restoring your ability to have that control and spontaneity and reliability back in your sex life. So who's a candidate? Anybody who's failed oral medication or patients who have a reason that they can't. Either the side effects are too strong, they take nitrates and they can't tolerate pills because of their blood pressure. So people are afraid of needles. They don't like to see needles, and they certainly don't like to see them next to their penis sometimes. So it makes sense. Guys with Peyronie's, who develop Peyronie's and erectile dysfunction, this is actually a great option because it corrects the erectile dysfunction and it straightens the penis all at once. And then one thing to know is some patients that can't really tolerate long bouts of anesthesia or extensive surgeries, this can actually be done. The malleable prosthetic can actually be placed under local anesthetic. And then, as I said, it is Medicare approved, and a lot of private insurances do as well. So the last thing I wanted to talk about, though, was what about patients who have leakage during intercourse or during orgasm, which is something that many men are able to control themselves on a day-to-day basis, but it's actually during intercourse that they have this problem. Pelvic floor physical therapy is obviously, spot number one. If it's small amounts of leakage, sometimes I'll recommend that patients use a condom. The downside is that in people who are already struggling with erections, decreasing the sensitivity with a condom can actually then prohibit them from actually having intercourse. A sling placement in general, when there's no lack of erections, is a good option as well because it can control that leakage during intercourse and high pressure events. And then there's another option in the men that have erectile dysfunction and leakage with orgasm, and that's at the time of placing an implant. There's a small little sling that goes across the urethra, and when the cylinders are inflated, that creates enough pressure on the urethra along with that sling and can really prevent that leakage from happening because it essentially just narrows things enough that nothing's going to pass through anymore. And so I'm happy to take any questions. I see patients in 4 places around San Diego, but happy to take any questions.
Well, thanks for staying. We want to conclude with some of the future. What are some of the things that are out there on the horizon that are pretty exciting, really? When I started in urology 30 years ago, I never dreamt that we would have so many options at this point in time. There was a time when prostate cancer, it just stalled out. Treatment stalled out. There just wasn't much going on. And now there's just been an eruption in things that are happening. So let's jump in and talk about it. So some learning objectives. We want to talk about some of the limitations of prostate cancer detection currently and what we're doing to improve detection. But the bottom line about this is please encourage people to get screened. It's still the number 2 reason why men die of cancer. It's the number 2 cancer cause of death. Do anybody know what number 1 is? What? It's lung cancer. If we're just talking about cancer, it's lung cancer. Smoking and years of smoking, and then even if you stopped, you're still at risk. So smoking and lung cancer is the number 1 cause. Prostate cancer is number 2. So why would we not screen for prostate cancer? And it's not about screening today, or I would have put all the slides in about how prostate cancer screening is actually more effective than colon colonoscopy and mammography. And so encourage people to get screened. We still see people who come in, young men in their 60s with metastatic prostate cancer. And the one question they ask us every time is, why didn't somebody check this earlier? So just go get checked. Okay, so what are some of the traditional things? Well, everybody's aware of PSA screening, but PSA, we're going to show, is not an awesome test. It was never intended to be a great test. It kind of got way ahead of itself. It was the doctors who developed PSA thought it would be a pregnancy test. You either have a significant cancer or you don't, but it got launched before they were able to do that. So that's it. Now, digital rectal examinations, we're doing fewer of those. And there are a lot of people in here of your age who they get really mad at us. Like, look, a good doctor always does a rectal exam. And my doctor always did a rectal examination. And you young guys, I don't know what's wrong with you. Well, the problem is a rectal examination, on a good, thorough rectal examination, we can feel about 20% to 10% of your prostate. And we used to think that most cancers of the prostate arose from the part of your prostate that sits on the rectum. But now we know with MRI imaging that we see prostate cancers in all parts of the prostate, and many of those you can't get anywhere near with your finger because they might be on the top of the prostate, under your pubic bone. So don't be offended if your doctor says, look, we don't need to do a rectal examination today. It's not all that helpful. And I'll give you an example of an exception, though, when you should demand it. And that's because if your PSA is abnormal, we're going to do an MRI. And the MRI is not just going to show us a little bit of your prostate like my finger would feel. It's going to show us 100% of your prostate. So what is the exception to a digital rectal examination? There's this thing that urologists fear, which is low PSA producing prostate cancer. So I met a person just recently, and they said, we were talking about prostate cancer, and he said, oh, you'll be happy to know my PSA is 0.3. And I said, that's impressive. And now I'm worried. He said, worried about 0.3? That's like, I'm record low because of this thing that we fear, low PSA producing prostate cancer. They are extremely aggressive. And so if your PSA is low, then make your urologist check your prostate. Because when we check the prostate, and including this month, I found 2 of those, you check the prostate and it's rock hard. And that means it's cancer. But it's the kind of cancer that is not producing PSA, and they're extremely aggressive. So if your PSA is a good test, MRI, a high PSA leads us to an MRI, and a really super low PSA in a 67-year-old man leads me to say, I need to check your prostate today to make sure it's not rock hard. And if it is, then we get an MRI, then we get a biopsy, then we find, oh, you know what, you've got a very aggressive prostate cancer. And all these years we got tricked. We got tricked and we were all happy until we found out that you had low PSA producing prostate cancer. So biopsies, we're going to talk about some of those things. One of the problems with PSA screening, just like I said, it hasn't turned out to be a great test. And I know there are men in here who've had a PSA that, it's been high, it's been low, you've been biopsied, no cancer, the PSA keeps going. And those patients make us nervous as well, right? We love it when things are consistent. And if your PSA is really high and we do a biopsy and we don't find cancer, we're just afraid we missed something. So there are a lot of things about that. We need better risk stratification. We'll talk a little bit about that. So one of the things that came along and really helped us was MRI. And so a beautiful study called the PROMISE trial showed that MRI sensitivity is about 93% for clinically significant prostate cancers. Now, there are a lot of nuances here because an MRI machine is like a very expensive D5 Nikon camera with a huge telephoto lens. The pictures you get all depend upon how you set it up. And some of us are old enough that when MRI came out, we realized that everybody was tuning their MRI machines differently. So some centers had great images that were helpful. Some centers didn't. And now, luckily, over the last 10 years, that's pretty much standardized by our radiologists. So trust biopsy sensitivity is about 48%. So for many men, if your PSA was out of whack, we just biopsied you. And we didn't have smart biopsies, which we will talk about. We just did 12 random biopsies of your prostate. And we either found it or we didn't. So the MRI came along and said, wait a minute, this can really help you fine tune what we're doing. So this is a multi-parametric MRI. You basically get 4 views of your prostate, 2 views without contrast, then we give you contrast, and we get 2 views, and we look at them to see if there's something that's suspicious that shows up. And we grade that on a PIRAD scale. So those of you who had an MRI, it'll say PIRADs 1, 2, 3, 4, 5. And you're like, I don't know if you know what that is. The higher the PIRAD score, the more likely it is you have prostate cancer. So roughly, if you have PIRADs 1 and 2, they'll usually say everything's normal. PIRADs 3, 30, 40% chance of having prostate cancer. PIRADs 4 jumps up to about 70%. And then unfortunately, PIRADs 5, it's about 90% chance you have prostate cancer. We all hoped that by 2026, the MRI would replace prostate biopsies. And I know you wish that was true too, but it's just not good enough yet. And so it could tell us whether you're likely to have prostate cancer, but it can't tell us whether it's aggressive or non-aggressive prostate cancer. So men will say, well, let's just do the MRI. And then it says, okay, it's suspicious. And they say, well, then let's not do a biopsy. Let's just treat it. But we can't treat it until we have a biopsy. So insurance companies will not pay for any kind of treatment unless we have a tissue diagnosis. So sometimes you'll hear about a neighbor who's an older person and we did a biopsy on him. Like, why are you getting a biopsy on that guy? He's 85. Well, he may have a PSA that's 10 or 12, and he may have bone pain, back pain, and we're worried about metastatic prostate cancer. We still have to prove that they have prostate cancer. So the MRI has been a big help for us. So the PROMISE trial showed us that with trust biopsies, this was your detection. And when we add multi-parametric MRI, it shows us that. Now, some men have pacers or wires or fragments from the war, and they can't get an MRI. And then we go ahead and just do a biopsy. So there are times when we do a biopsy without an MRI, but that's the real minority of patients today. Most men get an MRI and then a biopsy. We'll talk about why that's kind of important. It's called targeted biopsy. So there are a bunch of names for this. One is a smart biopsy. One is a fusion biopsy. One is a Euronav biopsy. And one is a targeted biopsy. But they all essentially mean the same thing. And that is that we do an MRI, and then the radiologists do a 3-dimensional reconstruction of your prostate. And then when we go to do the biopsies in the office or in the operating room, we can actually use the MRI images and overlay them on top of live ultrasound images. So here's the MRI, and the MRI says, oh, you got a spot right here. Your doctor needs to make sure he or she hits that spot right there. So in the past, we didn't have a way to guide us to that. And some brilliant researchers at NIH, led by the team of Peter Pinto at NIH, they came up with a way to create a very expensive software program and a computer system. It's about $500,000. And it takes your MRI images and it allows us to lay it on top of or fuse the MRI images with an ultrasound. Live ultrasound, and the MRI is on top of the ultrasound. They're all fused together, and as you're moving the ultrasound probe, it's scrolling through your MRI images. And it's a simple GPS unit that we put on the ultrasound probe. And then we can target the area of concern. And so we can biopsy that area 10, 15 times, top, middle, bottom. And when you leave the operating room, we can with great certainty say that we biopsy that area. And you either do or you don't have prostate cancer. Now, you're saying, well, that makes sense. But all of us at the table are old enough to remember when we didn't even have an ultrasound to do your biopsy. You had to guide your finger in the rectum with the needle on it and then try to get your finger out of the way before you did it. Then the ultrasound came along and said, wow, this is helpful. We can actually biopsy through the ultrasound. And then the MRI came along and we tried to picture this image in our mind and hope we hit it on ultrasound. And then the fusion technology, Euronav technology came along, and now it's just changed everything. And that's where we found out that a lot of prostates, so this is the rectum right here. This is the rectum right here. The rectum down here, the rectum down here. And this one just happens to be sitting on the rectum. But now we find out you got a lot of prostate cancer sitting way, way away from the rectum. And we just never realized that before. So the precision trial was to look at targeted biopsies versus standard biopsies. So in general, a standard biopsy is 12 specific areas. So we biopsy 12 general areas in everybody, and then we biopsy the target lesions, sometimes 10 times, sometimes even more, each target lesion. So patients will, just before you take them back for a biopsy, they'll say, well, how many cores are you going to take? And when we say, well, maybe 30, they're like, what? You should have told me that before I got here. But that's why. It's like playing Battleship in a really small field, all right? And we're trying to hit that ship. If there's a ship there, we want to hit it. And that's what it's like. Well, here's a beautiful trial. Standard biopsies were not as good as MRI-targeted biopsies. MRI-targeted biopsies, smart biopsies, fusion biopsy, urine biopsy outperforms just the standard biopsies. So as long as you can get an MRI, then we have a great chance that we can definitively say we hit the spot that was concerning. And some men just can't get an MRI. And if you have severe claustrophobia, which is understandable, Valium will usually get you through the MRI. It used to take an hour or so, and now it's really fast, maybe 20 minutes, all right? So don't fear the MRI. What else is new? Micro ultrasound, it sort of comes and goes, but it's a 29 megahertz ultrasound technology. And this is an example of 3 prostates with cancer. This one's easy to see. It looks like a kidney right there that the MRI missed, but this micro ultrasound was able to detect it. So this one shows up really well. These 2 don't show up very well, but on MRI, they didn't show up at all. But with the micro ultrasound, they showed up. So here's a cancer right here, cancer here, cancer here, cancer here. MRI missed it. All right, now, it reminds me to tell you that the MRI is not perfect. So the MRI can be wrong. So we have patients on a regular basis who get an MRI, and the radiologist says, you've got a PIRADS 4 lesion in this specific area. And remember our fancy technology, they say, okay, this is the worrisome area. We can guarantee we hit that, and it's not always prostate cancer. So then men are nervous. Like, wait a minute, what was that lumpy bumpy thing in my prostate? I read about PIRADS, it was 4 or 5, so I was already, stopping buying bulk at Costco. got my will in order, now you're telling me I don't have prostate cancer after all of that? And the answer is yes. The MRI is not a perfect test. It's a good test. It's better than what it used to be, which was me trying to find a spot with my finger without any imaging. It's better than that, but it's still not perfect. So there are times when they say this is very suspicious, and we can tell you that we hit the suspicious area because of our new technology, and it can still be negative for prostate cancer. So what do we do in that situation? We just watch you closely with your PSA, and there are other strategies we can use to find out if we need to worry about it. One of the newest things that's pretty exciting is called the Promaxo, and it's actually a portable MRI device. And you put it in your office, and the patient gets set up like this. So this is a patient in stirrups, and then you push this MRI image right up against their buttocks, and then you biopsy them with live MRI. So instead of ultrasound live, you do live MRI biopsies. And this is new. And it's just kind of catching on, but it's something that's very intriguing that we're thinking about pursuing here at Eisenhower with some of the other fun technologies that we're looking at. So Promaxo is brand new, live real-time MRI biopsies. So no combination of a fusion machine and an ultrasound machine and the MRI machine. It's MRI and biopsy all in one. So it's kind of exciting. So AI is going to change everything. I hope you're dabbling in it. I hope you're using chat or whatever you prefer just to ask fun questions and things. Try to get my dad to do that. He's at 88. He's really not having it. And so we have to use it a lot around him to try to get him, sort of buying into it. But it's really going to change everything. These deep learning modules are going to help us detect prostate cancer lesions that you just simply wouldn't have seen otherwise. It's certainly going to have a big role in radiology. And so that's interesting. Automated segmentation and risk prediction curves. All of this stuff is coming. It's coming quickly. It's just AI is exploding. These huge databases are exploding. And so you can load thousands, if not hundreds of thousands of MRIs and teach the machine how to read it so you don't miss it. And the MRI or the AI readers, they don't get in an argument with their spouse before they come to work. They don't come in hungover, right? They don't come in fatigued. It just does its deal, and it's a machine. So there's going to be a big role for that. Now, there's some emerging biomarkers, but there's something very simple that we're trying to get here at Eisenhower. I was very successful in getting this implemented in Utah when I was director of urology for Intermountain Healthcare. And then after that, I went to New York, and we were very successful in implementing it in the healthcare system of Northwell Health. If any of you are from New York, you will have heard of that. And we're trying to get it here. And it's a very simple thing. We have algorithms from data that help us risk stratify men based upon all the factors that make them unique. So let me give you an example how that works. Let's say you got a 58-year-old guy, and his PSA is 3.8. Is he in trouble or not? What would you say? Borderline. Somebody said, I don't know. Who said borderline? Borderline. You said, why do you say borderline? Well, that's just what I learned through my oncology. Okay, so borderline. Some 4 and down. All right, so four, so great. So he's saying borderline because 4 and above is bad. You're probably going to die, and under 4 is fine. Okay, so he's under 4, so he's just fine, right? So it turns out that his actual risk of having prostate cancer is between 6% and 53%. I know, that's what I thought when we found this out. So my mentor was Ian Thompson in San Antonio, Texas. He was a big prostate cancer researcher, and he's just a great human being. He's one of those rare people where you say, I want to be just like him. That's what he was like. So he did a beautiful study, and it was published 23 years ago. And it was called the Prostate Cancer Chemo Prevention Trial. And that's where we found out that this PSA cutoff of 4 was worthless. It was worthless. And this proves that. So this is how we presented, we reported PSAs in Salt Lake City with Intermountain Healthcare. And I didn't put Northwell's in there because we expanded family history and all of these things. So if my rectal examination is normal and I'm 58, I still have a 6% chance of having prostate cancer. But if I'm on some medication to help shrink my prostate or to help my hair regrow, you may have heard of Propecia, same drug, Propecia. It's a fun story, but Merck developed the medication finasteride to shrink big prostates to help prevent surgery on the prostate. And in those trials, the men who were on the drug wouldn't give the drug back when the trial was over. And when they asked them why, they said, because my hair has never been thicker, fuller, and beautiful. So then they said, oh, that's interesting. So then they spun that off into Propecia. So prostate dose is 5 milligrams, hair dose is 1 milligram, and it all came from trying to get men's prostates to shrink. Well, my mentor, Ian Thompson, in 2002 published the study, 18,882 men randomized to placebo or finasteride for 7 years. And then they all got a biopsy at the end of that 7 years. And the NIH shut the trial down because it was a positive trial. Ian Thompson thought that if you took finasteride, you might decrease the chance you get prostate cancer because of the way it works. We're not going to get into that because you don't care. And it turns out he was right. 28% decreased chance of getting prostate cancer if you took finasteride for 7 years, and your hair grew, so you wanted to live longer because you were so incredible, beautiful, and wonderful. So the other thing that came out of that trial is that your PSA cutoff of whatever, 4, 3, totally arbitrary and not helpful. You have to consider all these other things. So when we implemented this in Salt Lake City, we dropped biopsies by 30%. When we implemented it at Northwell in New York, we dropped biopsies by 30%. And we increased cancer detection, in both of those areas in men age 52 to 64. And that's the age group of men you want to screen for cancer, okay? So there are a lot of things we can do. There are other things. So just as a side note, that was free, right? We put the algorithm in there. Patients didn't pay anything anymore for that. And it outperforms all the other tests that are available out there on the market today. And it was free. All right, so what about these liquid biopsies? We know they're circulating tumor DNA. and DNA and tumor cells. So you have DNA and tumor cells and RNA circulating. Now, prostate cancer is very unusual. Men are often worried that if we get a biopsy, that we will spread the prostate cancer. And if we just wouldn't do the biopsy, it would just happily remain living in the prostate, in the confines of the prostate, and not migrate or transport itself out. So it turns out that tumors move according to their implant biology. And prostate just doesn't like to go many places. So it's prostate cancer is most likely what we call adenocarcinoma. And if you have colon cancer, that rings familiar because most colon cancers are adenocarcinoma. That's the first thing that's interesting. Second, we know that when we biopsied you, for years we biopsied men through the rectum. We don't do that as much anymore. And we know we drug prostate cancer cells from the prostate through the rectum, and nobody got prostate cancer growing in the rectum. Nobody. And you'll get big, bulky prostate cancers today that will compress the rectum. It never grows into the rectum. It just doesn't have the implant biology like that. Bladder cancer, if you were careless about that, it would grow wherever it drops. Interesting, gallbladder cancer, really aggressive cancer. And if the general surgeons drag that gallbladder through a laparoscopic trocar site, it will grow in that trocar site. Prostate cancer doesn't do that. We know that we can biopsy a man who has prostate cancer, and we can then do a polymerase chain reaction to magnify prostate cancer cells in their blood. And we'll find prostate cancer cells in the blood, and then we can still cure them with radiation or surgery. So it's very, very different. So we're trying to exploit all of this to see if there isn't a better screening strategy. So there are a lot of people spending a lot of money to try to prevent you from having to get a biopsy of your prostate. But in the meantime, we're not there. So go get a biopsy of your prostate. Okay, we've already talked about PSMA. I thought I'd show, people have talked about this a lot in our seminar. So this is a big advance. It's gigantic. Before the PET scan specific for prostate came along, we would have men and we would think, you have a super aggressive prostate cancer. You have a really high PSA. We don't think we can cure you with surgery or radiation. And it turns out that we didn't have a test to say whether the cancer was just living in the prostate or it was all throughout the bone. We didn't have that. And then there were other men who were on the edge, and we said, we think that we can radiate your prostate or take it out, and we're going to cure you. And then their PSA never went to zero because they already had metastatic prostate cancer. But we didn't have a way to find it. The funny thing about a PET scan is a PET scan will only work if the tumor you're trying to find will uptake or eat the isotope that we give it. So we inject something in your vein, and if you have a type of cancer that just doesn't eat that thing or take it up or bind it, then it's never going to show up. And we didn't have that for prostate cancer. And it's only been 4 years, I think, since we had a PSMA scan approved by the FDA. It's been in the works for a long time. Now we have it. So this is the scan. This shows a lot of uptake in the prostate. And then when we finally match it, line everything up, this is widely metastatic prostate cancer in the bone. But we didn't have a way to do that. Now we do. So it's really exciting. Theranostics, we already talked about it. The isotope that binds to this, everybody's in search of a new isotope that will bind, and it turns out copper 64 can be very, very toxic to prostate cancer cells. And then we're already talking about lutetium 177. So it's the same idea as the PET scan, right? Instead of just putting a marker that we send out through your whole body to find the cancer cells, we attach a radioactive marker to it that will bind to the prostate cancer cell, go in, and then destroy the cell. And that's kind of what lutetium 177 is doing. I know there's a startup company out of Park City. They're working on a copper. I think it's copper 67. Does that sound right? Dr. Patel, is copper 67 radioactive? All right. So there's a copper isotope that will do that same thing. So people are looking for this. Wouldn't that be exciting? We've done everything we can. You have metastatic prostate cancer. Boom. We send the cells scurrying through your whole body, and it just kills, attacks, destroys it like a really smart bomb. It's really exciting. So the trials are helping with that and is showing some improvements. Now, you have to know that if you have prostate cancer and it's Gleason 7 or above, that your sons are at very high risk for getting prostate cancer and your daughters are very high risk for getting breast cancer. I know. And if you have breast cancer in your family, your sons are very high risk for getting prostate cancer. So if you have breast cancer and prostate cancer in your family, you call the kids today and you say, look, you cannot skip your mammogram. And for men at the age of 40 with that family history, they have to get their first PSA. And that first PSA should be less than 2. So men over 40 get a first PSA if they have a strong family history of aggressive prostate cancer or breast cancer, and it should be less than 2. All right. BRCA mutated. There's some new drugs. We call them targeted therapies or immune therapies. So the old idea behind chemotherapy was we give you a chemical that kills all rapidly dividing cells. So what is one of the rapidly dividing cells that is very obvious when people got chemo? Your hair. So why does your hair fall out? Your hair falls out because it's rapidly dividing cells, and certain chemo block all the actively dividing cells, so your hair falls out. Sometimes your hair falls out because you're just genetically programmed to lose your hair when you get old. All right? But these are different. These are immune therapies that go out and they try to rev up your body's immune system to attack those cancer cells. And we've got a bunch of those in the works now. Nothing really happened for prostate cancer until about 10, 15 years ago, and then it just exploded. The techniques for radiation therapy just completely changed. It kind of changed. My example is a crude example. Dr. Patel may have to stand up and correct me. But when I was a resident, treating prostate cancer with radiation was like shining a flashlight at something you wanted to destroy, right? You destroyed that thing, but you also destroyed things around it. Now it's like a very fine laser, right? Turn all the lights off, shine the laser. I don't get a lot of scatter anywhere except at that thing I want to kill. So big advances there. And then big advances in diagnosis, big advances in treatment. And these immune therapies have been some of those. The blue line is control. And so the only way to know for sure whether these work is to compare it against either a traditional treatment or a placebo. And it turns out that the people who are getting these are living longer. We already talked about focal therapy. The idea, this is an interesting study because this comes out of the radiation oncology literature. So men got radiation, but the cancer came back. So they did really specific focal radiation. This is a patient who had a complete response. The tumor is right in this area, right here. And then they got treated. Here was the treatment plan. And then when they did the PET CT scan follow-up, there was no treatment. So there's only a certain amount of radiation your body can tolerate. And now we're exploring things we can do to say, okay, we already radiated the prostate, but maybe we can shoot a little bit more radiation in this area. Dr. Patel, did you have anything to add to that?
No, I think it just reflects the advancements in cancer care that across the spectrum that we're even welcome.
Wonderful. And then Dr. Hendricks talked about HIFU, high intense focused ultrasound. You know, who knew that you could use acoustic mirrors and focus ultrasound to create a spike of very high heat that kills tissue? So we all know about ultrasound, right? Because all of our grandkids got ultrasounded so we could find out if it's a boy or a girl, et cetera. And they didn't die. Nobody heated them up. And now we can use acoustic mirrors and we can actually destroy tissue. So it's pretty exciting. Yes?
Finding out with the ultrasound that you might have a scattering of any of the cancer cells?
No. And remember, even if you have scattering of prostate cells, they just don't go somewhere and implant. They grow locally for the most part. Right? They grow locally, then they get into lymphatics, they grow out to your lymph nodes, then they get into bone and grow locally. But even if you scattered them, they're not going to scurry around and end up in an unexpected place. Prostate cancer, for the very most part, tends to be very predictable. Okay, single port, we talked about that. Now, we see this kind of an abdomen a lot. Now, it doesn't mean a lot to you, except, wow, that guy's got a lot of scars on his abdomen. But what that tells us is that inside, that's what we call a hostile abdomen, a hostile environment. It means there are going to be adhesions and everything. Well, with the new single port robot, we can stay out of that abdomen and make an incision down here, not even go in the abdomen, but go into the pelvis. Your prostate actually doesn't live in your abdomen, and neither does your bladder. We consider those to be outside of the abdomen or the peritoneal cavity. And so you can go outside of the abdomen. So we'll show you just a little bit of, we're not going to watch this whole thing. So this is a 2.5-inch incision, and here is a camera and 3 instruments going in and an irrigator aspirator device. And on this side, we're going to take some lymph nodes out. This is what those robot instruments look like. And Dr. Hendricks did a nice job of explaining to you that, and he showed you the little things we put our fingers in. The robot is a misnomer. So robots actually do things independently, right? So robots build most of our cars today. They build our Teslas, they build our Toyotas, but the robot is not doing anything on its own. Nothing happens that we don't direct the instruments to do. So the robot does nothing on its own. In the future, it probably will. In the future, we'll take your 3-dimensionally reconstructed prostate and we will guide the robot. It will help us avoid the nerves that give you erections. It will help us avoid the sphincter, but we're not there yet. So this gives you just an idea of what it would look like when we have our head in the console. And it's really beautiful images. You can't appreciate it now, but the images are 3-dimensional. You have a left eye and a right eye, so they're 3D images. So this is, just to orient you, this is the prostate with the seminal vesicles. Prostate's a reproductive organ. The fluid that comes out with ejaculation is your prostate, and these little wings that come off of the prostate called seminal vesicles. And if you've ever wondered how sperm get from your testicle way down here all the way up to here, it's through the vas deferens, and it plugs in right there, right in the center of the prostate. That's how sperm get from there to there. That's how they get there. Okay, that's enough of that. I just think it's enough. You guys have been so patient with us. I just want to thank the cancer people, and I want to thank everybody who participated. So we really appreciate it.
Well, thank you. This was a wonderful night. Thank you to all our physicians and professionals who presented. We still have a few, we have the raffle, so please don't leave. And then at the, as you leave, we're having a reception where our physicians